So Jacob, tell me about oligoprogression. Do you biopsy these patients? Do you resect them? Do you radiate them? Or do you just switch to chemo? What's your
Yeah,
approach?
that's a great topic. So, and to me, this is relevant also to our prior discussion about using Pembro alone initially. But let's say you have someone who's on osimertinib with an L858R mutation, and they have progression at a single site. I would tend to radiate that site. In some cases, resect, although generally radiation, I think, tends to be easier in many cases. But if they've got multiple sites of disease that are all under control and a single site of progression, then I would tend to treat that single site. Now, would I test for some kind of resistance mutation at that time? Yes, very potentially. And in many cases, what I'll do is send cell-free DNA testing to see if there's something shows up like MET, for example. But in many cases, I'd be just treating that single site and then continuing osimertinib onward. Or for the prior discussion, Pembro alone in somebody who does not have a mutation, similarly, progression at a single site while otherwise disease control, radiate that site and continue the therapy.
And Leora, what about more clear, broad, widespread changing therapy type progression? How do you approach those patients?
So those patients will start off by sending cell-free DNA, if we don't get anything there and we're just still seeing EGFR, I might biopsy those patients. We're looking for things like C797S because maybe you're going to add erlotinib or gefitinib is what I've added for patients who have C797S, assuming that it's trans, or we're going to do, we look for MET because we have a trial for patients who are MET amplified, we're not looking for the MET exon 14, we're looking for MET overexpression or MET amplification. And then we're learning some of the other mechanisms of resistance to osimertinib. For the majority of the patients, chemo does become the next line of therapy. But if we can continue a targeted therapy or put them on a dual targeted therapy, that's what we've been doing.
And Josh, tell me about your experience about small cell transformation in these patients. Do you see it?
Yeah, we do see it, and it's scary, and we don't really have a lot of data about what to do in that setting. So I think that it's one of the reasons why I do tend to get both a plasma and a tissue biopsy if it's accessible, because knowing that someone has histologic transformation is important. And it's not just small cell. They can also have squamous transformation, as there was just a paper out of Sloan Kettering showing that is a common issue with the use of first-line osimertinib. I think that we know very little about mechanisms of resistance to osimertinib. All of our series are based upon very small numbers. So I think that knowing more with larger numbers will be very, very useful. I would say to Jacob's point that I think that oligoablation in targeted therapy is a little different from immunotherapy because we have actually a good amount more data in the targeted therapy space. We know resistance develops in a heterogeneous fashion. We know that a single site can progress while we can have good disease control. And there are good series that have been done showing that doing this improves outcomes in the long term, more so than any other treatment that we used for lung cancer. So I think this is a real space where we can help patients.